চেক হ্যালো। চেক চেক হ্যালো।
হ্যাঁ, জসিম ভাই কথা শুনতে পাচ্ছেন? জসিম ভাই,
চেক হ্যালো। হ্যালো হ্যালো হ্যালো। ভাইয়া শোনা যাচ্ছে আমাকে? হ্যাঁ, ওনার কথা। হ্যালো।
শোনা যায়?
হ্যাঁ হ্যাঁ, এখন শোনা যাচ্ছে।
আচ্ছা, ঠিক আছে, এখন ঠিক আছে।
কথা বলেন, একটু বলেন। জসিম ভাই একটু কথা বলুন তো আপনি।
হ্যাঁ, এখন ঠিক আছে।
হ্যাঁ, আমাদের কথা ক্লিয়ার শোনা যায়?
স্যার কথা বলবেন এখন কিনা?
ভিডিও দেখা যায় স্টেজ?
হ্যালো, ওই আপনার ভিডিও তো দেখা যায় না। কথা বলেন তো স্যার সাথে। হ্যালো, শোনা যায়?
হ্যাঁ শুনতে পাচ্ছি জসিম ভাই, আপনি শুনতে পাচ্ছেন?
হ্যাঁ, শোনা যাচ্ছে।
ঠিক আছে, ওকে।
ওখানে লোকজন কিরকম আসছে?
দেখা যায়, শোনা যাচ্ছে সবকিছু।
ও, থ্যাংক ইউ। হ্যালো, আমি এটা শুনে এটা শুধু আপনি ভিজে যাবে।
এটার উপর আরেকটা লাগা পর আমরা দুধের উপরে যাওয়া মাঝখানে। হ্যাঁ, উপরে আরেকটা লাগা। আমার ঠিক আছে, এটা একটু দেখুন। এই যে এসে পড়তে হচ্ছে তাড়াতাড়ি বলা জানলা বুঝে বসে একটা হ্যাঁ ক্যামেরাটা না আতিক, আতিক, হ্যালো আতিক।
হ্যাঁ জসিম ভাই বলেন, শুনতে পাচ্ছি।
আর একটু কথা বলবে? শোনা যাচ্ছে?
জি স্যার, শোনা যাচ্ছে স্যার।
কিন্তু ভিডিও যাচ্ছে না, না? ভিডিও স্যার এখান থেকে যাবে। এই ক্যামেরাটা পেয়ে ক্যামেরাটা অন করে, হ্যাঁ।
ভিডিও দেখা যাচ্ছে না স্যার এখন। জসিম ভাই,
হ্যাঁ,
আপনাদের সার্জারির ইয়েটা দেখা যাচ্ছে না ভিডিও। হ্যাঁ,
টান টান ট্যাপ ট্যাপ দেন।
খোকন ভাই আপনি একটু এদিকে আসেন।
ঠিক আছে, শুনবে আসতেছে উনি।
ওইখানে একটা ক্যামেরা
খোকন ভাই একটু আসতে বলেন না। আতিক, খোকন ভাই, খোকন ভাই, একটু আসেন, একটু আসেন। এটা হয়ে গেলে ওটা করে দিন।
Check, hello, check, hello, check, hello, check.
হ্যাঁ,
লাউঞ্জ রুমে আসছে সবাই আসতে কোনো কেন করে আমরা বলতেছে Jangan gespekan ini jelaskan kerja Korea
Hello. Hello.
আপনি বলেন যে রোমান আপনি পাসওয়ার্ড ইউজ করেন তাই না পাসওয়ার্ড ইউজ করেন
Assalamu alaikum, ladies and gentlemen, and all the respected attendees. Good morning and a very warm welcome to the very first annual scientific conference of Chattogram Lions Eye Institute and Hospital, EyeSighTech 2023.
Since 1960s, Chattogram Lions Eye Hospital has come a long way of providing expert and inexpensive eye care services and ensuring valuable gift of sight to millions and millions of people. With our continued endeavors and rapidly expanding team and resources, we have reached the very significant milestone of being recognized as a hub for academic institute just last year in 2022. After this massive success and radical infrastructural changes, all there was left was to gather the great minds in ophthalmology together in a successful scientific conference at our very own institute. And hence, today, we are extremely proud to be a part of such a massive event, the first ever annual scientific conference hosted by Chattogram Lions Eye Institute and Hospital. We hope
কোনটা ইয়ে বন্ধ হয়ে গেছে এখানে চেঞ্জ করে না এটা লাইন চলে গেছে কোনটা কোনটা 6 আর হেডফোনটা কই এটা বড় বড় হচ্ছে এটা বড় হচ্ছে ভাই তাও
ওটাকে শেয়ার করতে স্ক্রিন জন্য দেখতে শেয়ার ওটা শেয়ার
সাউন্ড না না
সাউন্ড নিয়ে কথা বলে না এটা কর কে শেয়ার দিচ্ছে
ওই পাশে
সাউন্ড বাজতে হবে ওখান থেকে দিতে হবে
হ্যাঁ তোমাদের টাইম
ওটা দিক দিয়ে ঠিক আছে আমাদের তো ঠিক আছে একসাথে
চালু 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 আছে মানে হেডফোনটা চালু আছে এই যে যেটা কর্ডলেস ওখানে শুনতে পারে কিনা একটু শেয়ার করে
Hello. 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 Now, we are going to start the very first scientific session of the day, which is the live surgery. For this very intriguing session, we are privileged to have with us today Dr. M. Majumdar, Professor Dr. Mujammal Haq Sharifi, and Dr. Altaf Uddin Khan as the three esteemed panelists. Respected Professor Dr. Jafar Khaled as the moderator, and finally, one of our well-accomplished, talented national leaders in ophthalmology, Dr. Mahbubur Rahman Chaudhary as the chairman. Today's expert surgical team will be led by three brilliant surgeons, Professor Dr. Shaukat Kabir, Professor Dr. Prakash Kumar Chaudhary from the National Faculty, and our esteemed guests, all the way from Odisha, India, Dr. Anurag Mishra, who we will have the pleasure to observe on the screen as they perform their respective surgeries. So all the panelists just arrived and all our guests are right here. I would like to announce their names once again for this session. Today's panelists, Dr. M. Majumdar, Professor Dr. Mujammal Haq Sharifi, Dr. Altaf Uddin Khan, the moderator as Professor Dr. Jafar Khaled, and the chairperson, our very favorite, Dr. Mahbubur Rahman Chaudhary, sir. I would like to invite all our respected chairman, moderator, and panelists to adorn their chairs on the dais and guide us through insightful discussions for this session. All the panelists, moderator, and chairperson, sir, please come up to the dais and you can take your seats on the dais. The session is just about to begin. And I'd like to request the moderator to conduct this session hereby.
Morning to everyone. Good morning to everyone. Am I audible? Professor Jafar Khaled. Dr. Nahid.
Yes, sir.
Dr. Nahid.
Yes, sir. Clear, sir.
Am I clear? Clearly,
Yes, sir.
the voice is okay, or I have to a bit loud?
No,
It's okay.
it's okay, yeah.
So, good morning to everyone. Sir is there? Hello?
Please give one mic to the panelists on the stage, moderator and panelists and chairperson.
So we are going to start within minutes. The first case will be done by none other. He needs no introduction. Professor Shaukat Kabir, one of the eminent ophthalmologists and phacosurgeon from BSMMEO. He will do the first surgery. The patient is Mr. Nepal, 60 years old, and the best corrected visual acuity in the left eye it is 160, and the cataract it is type 1, 2, 3, and 4, and the grade 2 plus. The pupil is well dilated, fundus not clearly visible. The anterior chamber depth is 3.91 millimeter, and the IOL power is 20.5 diopter. So we are planning to do phacoemulsification with 20.5 diopter foldable IOL under topical anesthesia. So we are waiting for the Shaukat Kabir. Thank you so much.
Assalamu alaikum. Good morning, everybody. Mahbub sir, Jafar Khaled sir, and other moderators. We are starting our cases. Hopefully, we'll good doing good.
Thank you.
Huh?
Hello.
Chattogram.
কোথায় শোনা?
এটা রেট্রোই হয় না?
Everyone,
Clear view, sir.
is it clearly visible?
Yes,
Yes,
yes.
sir. Clearly visible.
এটা একটু উঠে যাও। হ্যাঁ,
You want to take seat in front?
প্রকাশ, আমরা আছি এখানে। জাফর খালেদ বলছি, আমার সাথে প্রফেসর আবুর রহমান চৌধুরী ভাই আছেন। আমরা অবজার্ভ করছি, আমার মনে হয় আমরা চেয়ার থেকে ভালো দেখতে পারবো, কারণ স্টেজে থাকলে আমাদের ভিজিবিলিটি অনেক কম।
স্যার শোনা যাচ্ছে স্যার? জাফর স্যার?
হ্যাঁ হ্যাঁ,
Thank you, Shaukat. Best of luck.
Sir, thank you, sir.
Yeah.
This is a case probably grade 2 plus cataract, PSC mainly. I'd like to try direct job there, sir. So am I starting?
And
Sure.
we can see
Thanks.
the parameter that set up for sculpting is he will
Solid.
do in a continuous mode with torsional ultrasound 70%, and IB you can see over here 80, because he kept actually more vacuum 650 and aspiration floor is 40. So he is actually a very eminent phacosurgeon and oil control, so that you can see over here the so high vacuum and high flow rate, and corresponding he has also high IOP. It's the active
চাপ
fluidics.
চাপ লাগবে বাবা
The benefit of this active fluidics, so continuously
Chap, chap, like-
these machines, he can perform the surgery, entire surgery with a constant IOP. So he first made the side port, and through the side port he used viscoelastic substance. We can
and
see.
Midori and intracameral.
Now he is and also inject the intracameral
চাপ লাগবে বাবা
preservative lidocaine and mydriatic,
জেল একটু
and
জেল
main port also done.
চাপ চাপ লাগবে একটু হ্যাঁ একটু সহ্য করতে হবে
Dr. Prakash. Dr. Prakash,
I hear you.
can you hear me? Yes. This is a wonderful setup and congratulations to you and to your team. And we can see it very clear.
Because of you, sir.
Yes, thank you. And one question, all the parameters seems to be on the higher side. Is there any reason for that, Prakash?
Sir, it depends on the patient surgeon's experience and confidence. Usually I prefer low parameter, but probably Shakot Kabir, he is supposed to, is a very, with a high parameter, the procedure will be swift, as we all know, but there is some, though the process, but there is some compromised,
জেল দেওয়া নেই
that with the, but
না জেল সহ দেন
that is experienced surgeon, most of the extent they use high parameter.
Previously I started low parameter. Nowadays, sir, I prefer to do with high parameters with grade 2 plus or more.
So what he is telling that when he has started his career, he used to do with the low parameter. Now gradually with the experience, he is using more and more high parameter up, centration up. So now he is Rexis with the 26 gauge band needle.
Professor Shaukat, how is the red reflex?
Sir, I use retro, sir.
Are you using retro?
Retro and main light combination. Usually in my setup, I only use the retro, sir, in these cases.
No, it's going on very well. But from here, we've seen that the red reflex is little compromised. What we are seeing here from here.
Main light বন্ধ করা যায় না?
এই লাইটটা কি একটু সুইচ অফ করে দেওয়া যাবে কাইন্ডলি? লাইটটা একটু বন্ধ করে দেওয়া যাবে?
মেইন লাইট
না, আমরা আমাদের হলের কথা বলছি, সরি।
The high vacuum, we all know there is that the procedure will be swift, but there is a compromised, safety margin is a bit compromised. But it will depend on the surgeon's experience. But for beginner, we always recommend the
not to
lower
do so.
side for higher safety margins. Sir, do you agree with me, sir?
পাশের দিকে তাকান বাবা
Sir, can you hear me?
Yeah, please, would you repeat that, Prakash, please?
That for young surgeons, for beginners, the safety margin, for higher safety margin, the lower
বাতের দিকে
is
তাকান
the
বাবা
better
বাতের দিকে
for
লাইট
higher safety margin.
Absolutely right, yes. It is always better to be safe, and lower parameters
yes sir
gives you the safety, definitely. Your opinion, Jafar Khalid, please.
Yeah, it's okay. Lower parameter means what? I personally like the IOP within 30 to 40. So Shaukat Kabir has said it 80. I don't know. We want to see how it works. It is quite high for the patient's perfusion. So if it can be kept at the level of 40, maximum 50, that should be good. And vacuum, this setting is not for scalping. I don't know. He wants to do the direct chop. So that's why he has already set it for 650. I usually do with the scalping. So scalping is always in a very low vacuum, like 100 and 110. So his setting appears to be maybe very good for his direct chop.
Prakash, we have lost the screen. It's not visible now. Can you
Hello,
go
sir.
back to surgery screen, please?
Hello, sir. Sir, the screen is not visible.
Sorry for the technical errors. We are hoping to get into these issues very soon. Meanwhile, moderators, sir, we can go over the discussions and you can share your suggestions over just whatever we observed till now. Thank you.
The starting went very well, and Shaukat Kabir is very prominent surgeon, and his technique is of international standard. He's a very good teacher, and we want to see that his surgery is going quite well, but unfortunately, for due to technical error, this is at present is not visible.
As we were observing his rexis, it's quite impressive. He was using the viscoelastic substance only. He did not stain the cornea with the blue rex or methylene blue, but he directly done and he has done an continuous curvilineous capsular rexis in a formed AC with the methyl. I think he has used a methyl cellulose, and he was using the technology of retroillumination, and there's a partial red reflex, but still he could do it very nicely. And the rexis was quite impressive.
But what is the opinion of the panelists regarding the use of Blue Rex? Because whenever there is compromised visibility, it is quite safe to use Blue Rex. Do you have any comment or any suggestion?
Thank you. Actually, they are well-known surgeons. I wish to say it is not a difficulty for him. Somehow he can manage properly, I wish. It will be for us, staining of the anterior capsule is helpful for us. So, okay, I see something.
Yeah, dye blue is, I think, essential for the beginners, because in some white cataracts, but who are the already master of phaco, master of IOL, for them, many surgeons I see they don't use dye. Like Dr. Prakash, he sometimes don't use dye. In many surgeons I see, but for beginners, it's essential to use the dye, and some critical cases and some one-eyed patient, I think, not to be heroic, better use the dye. Better use the dye and to do the rexis perfectly and nicely. So the dye is essential for the beginners. And for many surgeons use dye during capsular rexis.
Altaf, do you have any comments? Yes.
Thank you, sir. In case of mature cataract, there is need blue for the better visualization. In case of soft cataract, like grade 1 or grade 2, it is possible to do capsulorhexis without glue. Yes, sir.
Sorry for the interruption, sir. There is a IQ. কথা শোনা যাচ্ছে?
Lost. Now we can see your surgery. I think you have completed your phaco part.
Yes, sir.
Nucleus management is complete.
Couldn't see that part, but we are waiting for your implantation part.
Yes.
Sir,
I think the cortex is still left.
no, sir. Some
Through with cortex?
no, this is the no cortex. This is the some epithelial cells. We will polish.
So what we can immediately see is there's a very nice round and central CCC that's looking at us from the eye. If there's any young mind watching this, then this is the way you should fashion the CCC, at least aim for it. Just about 5 millimeters and central and circular. Particularly, it's particularly important when you are planning to go in higher up and start the premium practice. So the torics, the trifocals, the EDOFs, they need to sit in the back properly. And the shrink wrap effect should be 360 degrees and it should be equal so that there's no post-operative tilt.
Thank you,
So,
Dr. Anurag.
Excellent Rexes in place. Excellent.
So we are using single piece.
The whole discussion about femtolaser assisted cataract surgery coming into the market and staying was actually to ensure that we have a proper Rexes. That's one of the defining advantages of femto vis-a-vis the manual Rexes. But if you have surgeons like him and producing manual Rexes like this, then probably you would not need the services of a femto machine. So look at the release of the IOL. This is an Acris of IQ coming in from the house of Alcon Laboratories. He has injected it in such a manner that it unfolds directly in the bag. So you don't need to dial it in. Pretty good tip, actually. If there should be minimal maneuvering inside the AC, you should cut down the instrumentation and handling of the AC to as minimum as possible. But what is showing here is extremely important. He's showing the visco removal after IOL implantation. Look at the way he's gone behind the IOL. So that's where the maximum pool of viscoelastic stays because we've inflated the bag. And once the IOL goes in, it forms a barrier to the posterior accumulation of the OVD that needs to be cleared, that needs to be aspirated. So he lifted the IOL optic edge, went underneath it, and now he's cleaning the viscoelastic. All of it from the bag.
Actually, this lens acts of center swell and lens memory is good. Thank you.
Realizing that we have used a combination of sodium hyaluronate and chondroitin sulfate as the viscoelastic substance for this particular surgery, it is utmost important that you should remove every last strand of viscoelastic from the AC before you form it, because the chondroitin in particular are short chain molecules, so that do not get removed that easily. So you need to take active measures, go to the place where you see a blob or a strand and actively attempt to remove it. Every last bit of it. Excellent. Very well centered. I think he injected a bit of preservative-free antibiotic. So moxifloxacin has gone in. Very good idea. I think we should all give him a big round of applause for a wonderful surgery, excellent beginning to the scientific sessions. We are all clapping in the OT. I think the audience is also joining us from there. So do we have any questions for sir? From the hall, from the panelists, from the audience?
Sir, I have a question. What is the benefit of coaxial in between of bimanual?
Coaxial IA over bimanual. Is that the question? Did I understand it right? Is that the question?
Yes, sir. Maybe
Please,
that is right.
please.
I think bimanual is better if you used to do it, because coaxial sometimes there is sub-incisional cannot good approach, and one of the most things that you can for expert surgeon you can does not need any viscoelastic for introduction of the IOLs also. This is the new procedure, because for removal you have to spend some more times, some more minutes for removal of viscoelastic, and and we can polish also the every part of the capsule, also anterior capsule and posterior capsule. You're right. I'm
Did it,
right.
Does that answer the question, or should we elaborate further?
You should add some.
Hello? Are we audible?
Yes, sir. Audible.
So does that answer the question?
Okay, sir. Okay, sir.
Yeah, so what he was saying was, it is slightly difficult to remove the sub-incisional cortex if you're using a coaxial IA. But the advantage it has is it uses only one port, so you might not need the second side port, which would obviously be essential if you're using a bimanual IA. So it's situational. Before we take further questions, I think we should, sir, you stay back with us because there could be questions from the audience. We go to the second case, and Dr. Prakash Chaudhary is going to operate. Sorry?
Oh. You could.
All right, so this is the patient parameters, the patient vitals. This patient is a male and is aged about 60 years. The visual acuity best corrected is hand movement. The B scan shows that the retina is on. It's a grade 4 cataract. The pupils well dilated. The ACD is 2.37 millimeters, so it's slightly on the lower side. And I think the moment it is focused under the microscope, you can see the reason why. It is an intermittent cataract. So the AC depth is likely to be slightly low because it's swollen. The K1, K2, there's hardly any difference between them. The delta stands at 0.25. So we can jolly well plan a monofocal hydrophobic IOL for this patient. I would just request the OT to have some quiet, please, because the sound is transmitting to the hall. So the calculated IOL power with SRKT is +17. And what we have planned for this case is the Alcon single piece, Alcon Acrisoft single piece, premium hydrophobic, non-preloaded IOL. So that's about it on the patient. And from the first look itself, you can see the reason why we were saying that it's the AC depth is low. What is observed out here is the cataract's definitely hard, it's peeping at us. But what we can also see is wedge-shaped fluid-filled pockets in the mid-periphery. Now that's actually always a red flag. Whenever you see that, that's always a red flag. So you have to plan every step from now on. Plan it deep inside your mind and execute it on the OT. This is a fantastic habit of bending your own needles for capsulotomy, because the assistant, when you're operating elsewhere in somebody else's OT in particular, might not know which angle would be most suitable to you. So you need to have access to all corners of the capsule. So it's always a good idea to bend your own needles, provided you have the time for that. So topical anesthesia is going to be the anesthesia for this case. I forgot to mention that, but I think the way the patient's eye is moving, you can jolly well make out that the patient's being operated under topical anesthesia.
Sir, what is the preference in these cases? Either you do topical or local anesthesia?
Topical is fine, unless the patient's using massive pills and the eye is being lost underneath the lid. Topical is fine. So in very few specific cases, depending on the patient profile, we choose whether to block the patient or not. Every patient after the first 15 to 20 seconds, look at the patient now. He was moving the eye so much initially. Now
Yeah.
he has settled.
Settle, yes.
So after the first 15 to 20 seconds, usually the patient settle. They know where to look at. They know they have to keep both eyes open. They do understand your commands. They do act accordingly. If the patient fails to do all that, then you always have the choice to block the patient on the table itself. So no need to plan for it well ahead in time. But what is important in here is to plan this. Somebody of Prakash's caliber would have already done it. He would
Yes,
have
sir.
already formed a mental plan as to how to go about. But then, I mean, however experienced you might be, these always create that little bit of jitter just before you start. So, in the ocular surface, A, it maintains the corneal hydration, keeps it clear. And B, I think povidone iodine must have been used in the conjunctival cul-de-sac before surgery. So he is ensuring that all of that is washed off. Eye.
Huh?
So what's the generalized consensus? I would like to ask the panel. What's the generalized consensus of preparing the asepsis of the patient before they take the povidone iodine alone? How is the patient prepared? What do you do? Anybody from the audience or?
It's a very important question, I think, preparing the patient by this. There's the skin preparation. There are two parts: the skin preparation, the lid margin, and also the conjunctival sac. So I think the povidone iodine 5% is good for skin as well as the conjunctival sac. But how long it should be there? That's the question. Many surgeons are afraid of having damage to the cornea. But from my experience, I can tell that 5% povidone iodine is not toxic to the epithelium, corneal epithelium. So at least for 3 minutes to 5 minutes, and then washing it with a BSS is okay. And then and very good draping, covering all the parts of the lid margin. This is really an important. There should not be a single eyelash coming out from the under the drape. And once we ensure that the lids are under full cover of the plastic drape, then we should feel safe that at least there is no commensals that come into the conjunctival sac.
Okay, can I start?
Please start, sir.
Good morning to everyone. So I'm going to start my second case. As you can see over here, this is a white, hard, and intermittent cataract. And along with it is a very deep socket. So there are a lot of challenge over here. My plan is over here. First, the challenge is over here to make a complete optimum size rhexis. And to do that, my plan is to do initially decompress the adequate decompressions of the capsular bag, initially with the 26 gauge needle, and later on with the bimanual aspiration of the cortex. And another thing is I'll try to do 2-stage capsular rhexis. So let's begin the case. First, I'm making a side port. Here I'm using 1 millimeter MBR blade, with which I am comfortable with any. This is mostly useful in case of deep socket. So now I'm using.
What is the magnification you are using for from your microscope? Is it very high for you? The magnification.
Which is high, no?
Hmm.
I'm using
I think the depth of
the
perception.
skin, it is not visible.
Mhm.
Now it is okay.
If you're comfortable, that's fine. It's not nothing to do with us. It's up to you, after the surgeon.
Change the magnification change.
What normally happens is
Hey,
the moment
Kamrul,
the
Kamrul.
image goes to the beam splitter and the camera, it actually gets a little magnified. So what we see and what is projected is a little different.
Okay, if the surgeon is comfortable with his magnification, that's fine. Then no need to change.
Are to come on. এখন ঠিক আছে আর একটু কমা no আর একটু কমা no okay now the magnification issue is okay.
This is okay with us as long as you are comfortable.
Okay, thank you so much. So now I'm using intracameral lidocaine hydrochloride with my diaries to eliminate the pain sensitivity during fluctuations of the anterior chamber and to eliminate the pain sensitivity of the iris, ciliary body, and choroid. So now I'm using the dispersive OBD. The dispersive OBD has more negative molecular charge than the cohesive OBD, and that is better absorbed by the positively charged corneal endothelium. And that's why it has better coating ability. Under the dispersive OBD, I'm using the cohesive OBD. It is a high molecular cohesive OBD, and it will push the dispersive OBD up to line the corneal endothelium. So now I'm making the second side port because I do bimanual eye to remove the cortex with the same knife. Sorry for. Next, I'm making the main port. I'm using a spatula as a second side port so that I can manipulate the globe. In the deep socket, it is very, change the blade.
Something that I don't know about the rest, but at least I was expecting to see was a stain on the capsule. You're not staining it. Any particular reason why you've not stained it? I mean, you don't stain such.
I'll do that later on.
Okay, you'll do that later. No, but it's again.
There are different stain technique is there. We can stain under air bubble. We can directly inject the tip and blow in the anterior chamber. I prefer to do it under cohesive OBD.
That's interesting. So there are two reasons why we do this soft shell technique, as was described by Stevie initially. The dispersive viscoelastic is a wonderful tool to coat the endothelium and protect it from the thermal damage that could come later on.
So the main port is made and I achieve the esco-achievement incision, which is good for better sealing. And now I'm using the tip and blow to extend the anterior capsules. So the side port, I am using the tip and blow and I am with the under surface of the cannula, I'm just spreading the blue. The main advantage of this technique is does not allow the anterior chamber and pupil to get collapse and greatly enhance the visibility without touching the corneal endothelium. Look at the light, please.
Very interesting take. I'll definitely ponder on it a little later in my practice. What he has done here is actually not called staining, it's called capsular painting.
Yeah.
So little quantities of dye released here and there so that it diffusely distributes itself and then paints the whole surface. Excellent technique, I must say.
And now I'm washing the tip and blow with the BSS. As we use, that is sodium hyaluronate, these are long chain molecules and highly entangled with each other. You see, very easily they can move. বাবা একটু নিচে সরে more height.
Plus, it is not staining
Later,
the
later.
visco. So normally with the short chain molecules, if you put in the dye, it will change. It will also stain the visco. Here, and it's not staining the visco. Excellent take.
Still, if you are not happy with this staining tip pen. So you see on my right side, the capsule is not stained. So at any point, I can again use the stain because it is a white cataract, intumescent cataract. I don't want to take any risks. The patient is moving eye actually. Cohesive. Hyaluronic. Okay.
Do you prefer in this case to use the forceps for capsulation?
So I use the capsulorhexis forceps only when I feel that there is a threat of the capsule running out. Otherwise, it's usually the capsule from the needle that I'm more comfortable.
So now I'm going to now I proceed to decompress the capsular bag. As I told initially that I will do with the straight 26 gauge needle, the bevel down through the side port. Just puncture the anterior capsules in the center of the anterior capsules and give a cruciate incision to divert the force of tear. And I think there is no fluid. So probably this is not too much intumescent.
There's no milky fluid.
No
that
fluid.
stains. We can see fluid-filled pockets.
Yeah,
Those
there
are
is some fluid
gelatinous-
pockets in the anterior cortex.
These are the gelatinous material that's actually bound by those septae, microseptae that are formed by, again, compression of the anterior cortical fibers. And they exist in the mid-periphery. So, I mean, there's always a word of caution that it's true that these capsules are extremely difficult to decompress. You can't draw or aspirate any fluid. But at the same time, they do exert some pressure, but you should not have an issue in this particular case is what I believe. Yes, so it's moving quite nicely, actually. Yeah.
Babaji চোখ নারায়ণ না hyaluronic. The patient is বাবাজি চোখ সোজা রাখেন সোজা সোজা সোজা. Still I'm not I don't want to take any risks, so I try to do 2-stage capsulorhexis over here. Babaji.
And something we can notice almost instantaneously is that he is moving it clockwise. The rhexis is being moved clockwise here. Most surgeons do it anti-clockwise, but it's always a word of advice to the young Turks to learn it both ways, because it actually comes in handy in specific situations. You can stick to one technique which works the best in your hands.
So
Beautifully done.
বাবাজি আপনি সোজা লাইটের দিকে তাকান মাথাটা সব নাড়ায় ফেলতেছে. So initially I create a very mini rhexis. Now I proceed to further decompress the capsular bag with the bimanual eye.
The best method that works the best in my hands in situations like these is to rotate the nucleus manually. That actually breaks the
fluid on
that's there inside after doing the primary mini rhexis. But I mean, each to its own. So sir does it differently.
I think it is well focused.
No, it's focused, sir. It's properly focused.
So very careful. I am extremely thick swollen cortex, but the capsule is very thin and fragile. So the maneuver of the aspiration probe, there is a possibility of the rhexis tear. Okay. Hyaluron.
Because if we rotate the focus of so that is probably
Fluid
going
below
to-
succurrent. For take out my irrigation, I am again injecting the cohesive OVD. Every time I do that to maintain the stability of the anterior chamber. So I'm changing my hand to aspirate the cortex from the other side. for adequate decompressions of the capsular bag. On. Okay. Once the nucleus start to rotate, that is the end point of adequate capsular decompressions. Now I will use dispersive OBD again. Before take out my irrigation handpiece, cohesive. Now under the dispersive again, I am the cohesive and ideal soft shell technique so that it will take care of corneal endothelium during my phacoemulsifications.
Sure, everybody would be waiting to see how you actually expand this rexis and how you
So
spell it out.
now I will give a tangential cut
With the needle?
with the micro scissors. To the bubble letter. The main difficulty I'm facing, the patient is a very moving eye.
So what size of CCC are you aiming at, sir?
I'd like to do 4.5 to 5 millimeter, a bit more because
Irrespective of the grade of cataract.
yes,
for this
in the hard cataract a bit more.
So this is something everybody should practice. Going in through the sideboard, using a micro for capsule, and then spiraling it out. This comes in very handy when you have a situation like an intermittent cataract, like this, or even higher. Because the AC stays formed, the globe stays formed, the viscous pressure is always on the capsule. You're not producing any leakage. It also is helpful in cases wherein you have a membrane on the posterior capsule, which you want to remove, tags of capsules after you've completed your surgery. So the side port is an excellent fulcrum through which you can introduce your instruments and work, provided you are used to it. So I would recommend to start doing it even in normal cases, so that when you have a tricky situation.
So I'm lucky to have a good optimum size rexis. So now I'll proceed for a sculpting. I avoid actually any nucleus rotations in the hard cataract, any white cataract, because I don't know the status of the posterior capsules. Can I get a scissor?
Because if we practice with the side port, the antechamber is well formed and
okay,
there is no
sculpting.
chance of extending the capsular towards the periphery. That's a good technique. I mean, I think our residents would learn by doing the micro forceps or side port.
Yes, and you also need to be ambidextrous with that. Use the forward and left. Some hands should be stronger, some hands should be weaker. Every human being has it, but you should have the habit because that will give you the maximum torque. And when you are right opposite the area you're handling, it's always better. I mean, look at the circularity that has been maintained in the capsule.
So now I proceed for a sculpting. Here you can see my parameters for the sculpting. And my parameters are for torsional. I'm using the torsional ultrasound 70%. The on time is 250 millisecond and off time is 50 millisecond. IV I kept 40 and become very low also 120 and aspiration 25 because in the sculpting actually the main parameter is the ultrasound. Vacuum and flow only just to take out the nuclear materials that we emulsified. So my aim is to create a deep and wide groove over here. First, in the epinucleus mode, I take out some, give me water in the, I can't see anything, wire bubble. So I'm taking some epinucleus so that and some viscoelastic substance so that to prevent the clogging of the phaco tip. Scouting. Power. Power 80.
So what we can observe is he's expanding the trench. The width of the trench is something he is expanding. He is going wider so that it gives him better access to the deeper planes. If you construct a narrow trench to begin with, travel to the deeper side of the nucleus will be restricted. So it's a very good idea just initially so that the deep nucleus, the harder endonucleus portion is visible to you and you can access it. What Prakash sir probably forgot also has his IP switched on. So the moment it reaches a particular vacuum level, the longitudinal phaco also operates. So that's also a good idea. Very good idea, in fact, for harder cataracts. You go with torsional, and when the vacuum reaches, meaning if you are deeper in, then the longitudinal also starts operating at a particular frequency so that the deeper nuclear substance is attacked.
Okay, now I proceed for chopping.
Very nice trench, sir. We can see the red reflects through the floor of the trench. That always indicates the end point. So we have weakened it sufficiently. The harder central endonucleus. Now the periphery can be chopped. You can just hold it and chop it, which he would be doing in a while.
Prakash, can you center the microscope?
Yeah.
I think patient is moving too much. Yeah. That's now we can see it.
Okay, I am facing difficulty in chopping, so I'll do again a sculpting. This is a very deep socket. And now I'm seeing that the anterior chamber is very deep. So now I'm using the multi-level chopping. First, I bury the phaco probe with the 60% torsional ultrasound to occlude the phaco tip. I'm pulling, then lifting up, then with the chopper, I initiate a crack, and gradually I'm moving my chopper down and down because complete anterior posterior separation is very difficult over here, and which is very crucial to merge with the fragments into the posterior plane. বাবাজি উপরে তাকান, উপরে উপরে। পাওয়ার 60, পাওয়ার কত? 60, পাওয়ার make it 60. পাওয়ার 70 করো। ওকে, সব ভেঙে যাও। এইটি সব ভেঙে যাও। বাবাজি উপরে তাকান। ওকে, ইয়েতে যাও। 80 কর, 70 কর। পাওয়ার কত? কত কর? কত কর? So now I am doing this passive OBD to the, as you can see, the pupils get small down because the one hemic place is not chopped well. So underneath the, again underneath the, with this passive, I'm using the, দেখি বাবা ছোট ছোট লাইটের দিকে তাকান, আপনি লাইটের দিকে তাকান, লাইটের জামি নিচে রাখেন, এখানে জামি নিচে রাখেন, জামি, হ্যাঁ। আপনি সোজা লাইটে থাকান, হ্যাঁ। সেন্টার করো তো, সেন্টার করো, মাইক্রোস্কোপ সেন্টার। শপিং এ যেতে হবে না। দাঁড়াও আমি বলতেছি। This part is not. Shopping. There's a flow rate. Okay, quadrant one. Here I kept my IP on because as we all know in the torsional ultrasound, this is in the center. So there's a special for it. So when more and more fragment is removable, I gradually reduce my all parameters to take care of posterior capsule. So before take out my irrigation handpiece, I inject the dispersive with the sideboard. Please একটু সোজা লাইটের দিকে তাকান না, লাইটে বাস। So now I think most of the nucleus is removed, nucleus is emulsified. There is very cortex, very few, though I moving for to remove the cortex with the bimanual IA. The main advantage of the bimanual IA prophenda. As irrigation and aspiration handpiece is separate, so it greatly maintain the stability of the anterior chamber. a tube. So hardly there is a very little amount of cortex because it is an mass cataract. Oh. Hyaluron. So again, before changing my hand, I am injecting the OVT. This I routinely practice to maintain the stability of the anterior chambers. সোজা লাইটে তাকান আপনি জামাটা নিচে রাখেন আর কি হ্যাঁ so the actually every time I have better focus and centration because I'm not patient is anchored. So again by minimal IA. IL, load IL. So done, I think. Is it clearly visible? I will do hard implantations. Top on the cornea. About 60. Okay. So now it's time to remove the any OVD left behind. So it's very important to remove the OVD from back of the IOL because if any OVD left behind, that will cause a sharp rise of intraocular pressures post-operative period. And thorough removal is very important to any post-operative infections.
Prakash, what type of lens you have used? What is the brand?
Hydrophobic.
Is it
So
you mean that this is
done. Now I'll go for side port hydrations. There are a lot of difficulty was there. The people was get constricted during the procedure and I was not able to chop according to my expectations.
It was a wonderful surgery. It's a heroic surgery because the patient was not very stable. He was moving his head. I just wanted to know, did you use any parenteral medication or anybody giving any sedation or analgesics?
No, routinely just we use the that is midazolamide, half milligram.
Yeah, as this sort of surgery takes a little longer time, and you are on surface anesthesia. This sort of patient should be stabilized with
that should be at the IV midazolamide.
Midazolam, and sometimes my anesthesiologist is there. If they use the propofol. Propofol is really an anesthetic drug which causes a very short sedation and pain relief.
So the let it. Thank you so much.
Thank you, Prakash. Wonderful surgery. Lost from us.
Yeah.
Very difficult situation because the patient was not cooperating, and your technique was wonderful, and you have shown us how to tackle a difficult situation and also a difficult cataract. So this went very well, and this is a learning for all of us who have been watching your surgery. And every steps, you had a unique choice of yours, and which is very logical and which sound very logical in the sense that from the staining that you have done, the way you have done the rexes, and the way you have done the sculpting, it was white sculpting so that you could see inside very well. You could go deep inside your tunnel. So these are the something that we need to learn, and how you overcome the difficulty of chopping. So you have done it very well. Congratulations to you. Thank you.
Thank you, sir. So about the third case.
Hello, Prakash. Well done. Very wonderful surgery. Despite of all the patient, I don't think that patient is that much. Patient is also try to give the patients as the surgeon, like the surgeon. We are thinking that Jami ঠিক রাখো, চোখ নাড়াবেন না, কিছু করার নাই, কারণ এর মধ্যেই আমাদের করতে হয়। And Prakash has done it so nicely. Professor Mahbub and Jafar Khalid has said that despite of all the drawback, you have done a very good job. I also think so. Thank you so much, Prakash. Thank you.
Prakash, do you think in this case, while you're doing sculpting, you should have gone a little deeper in the center so that the chopping would have been easier? Do you have any comment on this, please?
Audio from the OT is lost. We can see you, but we cannot hear you.
Temporal.
Now, I think it's all right now.
I don't want this. Remove this, please. Yeah, remove it. I want the Pico foot switch there on the left side. Yeah. Wonderful. My instruments have come.
The most challenging thing we have seen during the chopping is that people was getting smaller. And that's the major challenge during surgery. Luckily, we did not see any prolapse. It was not a floppy iris, luckily. But many of these hypermetric cataracts comes with a floppy iris, and that tends to prolapse to the wound. And that's the situation makes even more difficult, and it's sometimes painful for the patient also. So, so he was maintaining it by giving the OVG repeatedly, and he kept them people in the middle level, and he could finish it. So during this type of surgery, if the iris is prolapsing or the pupil is getting small, the first tool is the armamentarium, is the I think the viscoelastic substance. Then if it is not working, then we have to give some intracameral
Ready? Then
dilating agents.
So we
And
are-
even in the worst scenario, we may have to put the high-risk hook. Professor Dr. Mahbub Rahman Chaudhary, what do you think? How do you manage it?
Yeah, Prakash, are you there? Can you hear me?
Actually, that so before going to start the third case, just I explain what difficulty is difficult. So initially, my plan was that actually always that deep and enough deep and wide group scouting, but I could not achieve it because the anterior chamber was so deep and because of moving eye, I could not appreciate the depth of the chopping. And that was initially I faced, I could not, I could not achieve the chopping. Then later on, again, I go for scouting that I learned. And then I go for the multi-level chopping. When I go for the multi-level chopping, then I achieve.
Saline, please.
But one heminucleus still
Saline.
it was not chopped.
Hydro.
So what I did actually, I take out the one
Saline.
heminuclei, then I rotate, and again I try to
For hydro?
do a scouting and
My cannula, where's my
and then
cannula?
successful. But another problem that I
Oculan?
face during
Same
the
cannula
procedure,
with
the
hydro.
people get constricted. But
Same.
this
Change it afterwards. Put it back, put it back. उसको वापस लगा दो, Oculan पे.
yeah.
Okay.
Okay, so we are going to start the third case. And
This is Oculan?
done by
Okay,
the
same
name
time.
other than Dr. Anurag Mishra. And as you all know, he needs no introductions. The patient is Mr. Ruhul Amin Bhuiya, age 75 years. And he's on, triamcinolone for 4 years. And the pupil is mid dilated and it is a soft cataract. And pupil is mid dilated and patient is diabetic also. The anterior chamber is shallow 2.87 millimeter and fundus looks okay. So our plan is phacoemulsifications with the 21.5 mm foldable, 21.5 diopter foldable IOL under. Okay,
You have it?
over to
You
Dr.
have it?
Anurag Mishra.
Where is it?
So the main challenge over here during IPAS, that is making a perfect optimum size axis. And as we know, with the triamcinolone, there is a possibility of the iris prolapse in top the floor. So over to Dr. Anurag Mishra. Are you ready?
Thank you so much, sir. Am I audible? Am I
Yes.
audible?
Yes, sir,
yes.
audible.
Have the feed from the microscope yet?
We don't have the feet, sir.
Yeah.
We have it.
No? All right.
Have it.
You heard the patient parameters already, and as you can expect, the pupil is a. Now, this is my way of creating incisions. I don't anchor the globe at all with forceps. So I take the two blades together. This is the side port blade, and this is the main port blade. The side port holds it, enters a little, and then holds it, and the main port creates the main incision and comes out. And while the side port withdraws, there's just a wee bit of extension to that according to my desired size. The third port is also made in the same sitting. So without putting in any solution into the intracameral plane, all the three ports are made at the same sitting. So nothing goes into the eye before the ports are made. Oculan, please. So we'll put in some preservative-free lignocaine, as we have seen in the other two procedures as well. This actually makes the patient hugely more comfortable. And I also tend to put drops of Oculan at the ports so that the sensation of the cornea, methyl cellulose, please. Methyl cellulose only, nothing else. So I don't use any other OVD in my routine practice. If it's a very hard cataract, I would just use a bit of viscoat to coat the endothelium. Otherwise, it's all methyl cellulose. I don't use chondroitin and sodium hyaluronate or the combination of those two. Capsulotomy needle, please. For the AC formation at all. So we proceed towards the capsulotomy. It is a mid-dilated pupil. Minimize the red glow. I operate under relative magnification stays at around 0.6, 0.65. I always believe once you go down on the magnification, the resolution actually improves. So it covers a wider field. It's easier to document your surgeries. And it also improves the resolution. Please look straight. Can somebody help me with the language? No, not. I didn't say that. I just said somebody help me with the language. Please tell the patient to look straight in the light. Hydro. So my rhexis is complete. I just hydrate the cornea a little bit before going in and producing the hydro procedures. From the left and from the right hand side. It's relatively more dense on the right hand side of mine. So the fluid wave is easier to see from the left. We saw the fluid wave. Now I billowed the nucleus. Now, as you decompress the cataractous lens here, we can already see that the iris is playing around with us. The iris is trying to foul play. The iris is trying to come to the port. So this is a patient wherein we can expect intraoperative IFIS. We know that the patient's on tamsulosin. So we have a few strategies in mind. The nucleus rotates freely. The hydro is complete. Now it's time to put on things into action. So when I use the phaco handpiece in such cases where I'm expecting IFIS to happen, the first thing that I would obviously like to do is to ensure that I have a proper wound size maintained, which is 2.2. And then the fluidics should be low. So you're not using, that I know. I think it has some air bubbles in the pipe. That is why I'm not getting a proper anterior chamber. Yes, it has some air bubbles. I know the parameters are my parameters, but somehow I'm not getting the same depth of the AC. It probably has some air bubbles. Yes, it has air bubbles in the irrigation line. Whatever. So coming back to the point I was making, so the fluidics are kept low. The IOP, I always operate under an IOP of 20 actually. It's not about this case alone. It's not about specific situations. But the only difference that is there in my machine is my machine has active sentry. And active sentry is another phenomenal addition to the Centurion Vision system, which actually controls your IOP right at the handpiece. So if you look at the behavior of this particular iris, though the patient definitely has symptoms of IFIS, it's not fluttering a lot. Okay, so I go in, I catch hold of the nucleus, and I chop. Can you see the crack? Is it centered? I can't see.
Yeah, it is quite well centered. Yes.
So it's actually easier to center the eye when you're operating under low mag. It's a very soft cataract, as Prakash sir was mentioning at the beginning. So when you're using advanced technology phaco machines, the softer cataracts are actually the harder bargains. So I'm hardly using any power. I'm just holding it and mechanically chopping it, trying to separate the nuclear fibers and carve out a wedge or a pie. It's difficult to hold these nuclei and chop them. At any time in such cataracts, you should be prepared to hold the chopping process and go to trench.
Be more helpful, useful to deal with the soft cataract?
Well, I mean, you can. 4-quadrant is not something that I normally do, but yeah, stop and chop is something one can certainly look at. The idea is to produce a trench so that it's easier to, it's very difficult to hold this nuclei for chopping. You can't hold them because they're so soft. The moment you're trying to hold them with vacuum, the vacuum gets lost and then you lose the hold. Then that produces an incomplete chop. So I completely agree with you. At times it is imperative that we trench them. Oh my God. There are a lot of air bubbles in the irrigation line. I don't know from where they came. It's difficult to contemplate that at times because Centurion is a closed system. So it should not allow air bubbles to go in. But at times you just cannot explain things. And look at the pupil. It's starting to come down as expected. So one must be ready with the presumptions of all these. It's always a good idea to emulsify most of these nuclei inside the bag because the pupil's just waiting for a mechanical trauma to happen to it. If you touch the iris with the help of your instruments, or even if the nuclear fragments touch it, it just goes down further. So one must be careful not to touch the iris. Of course, it's inevitable when you're trying to, lever out the nuclear fragments for emulsification. It's inevitable. You would touch it. The nuclear fragments will touch it, but at least you should try to cut it down to the bare minimum possible. You're almost done with the nucleus. There's just a small piece left there. Yeah, we're done. We go to the IA mode now. Look at the CDE. It stands at 5.87. That's very low, and that's where you should try to keep it. So irrespective, no, coaxial. Irrespective of the dialer, please, in the left hand. So irrespective of the solutions you use to protect the endothelium, bring the fluid usage and the energy usage to a minimum possible, to a bare minimum possible. Just a moment. Because once you do that, irrespective of whatever solution you use to protect the endothelium, it will still receive its share of damage. So these things that actually that you're producing inside, the heat that is imperative to come when the phaco needle moves, and then the fluid, because there is a turbulent mechanism that is operating inside, turbulence, that also damages the endothelium or at least attacks it. So you should aim to bring it down, both of these, the fluid consumption and the energy consumption, to a minimum. It's tricky when you have a small pupil and you're trying to clear out the cortex. It's a little tricky, but this is one technique that helps. The second instrument just retracts the iris a little bit, and then you can catch hold of the wedge of the cortex. Give yourself some time, think about it, breathe, stay calm is what is called for in all the tricky situations that we face. Anything specific anybody would like to know?
Dr. Mishra, would you like to put some lignocaine at this stage?
No.
To dilate the pupil?
No. Lignocaine I would put only if the patient's complaining of pain, or I get to see or I get to hear the whimpers, the oomps and the ahs. If that comes in, hydrocannula, please.
And what about adrenaline?
Acha, you're talking about adrenaline? Adrenaline I would put at this my IOL implantation. Can you load the IOL, please? Can you prepare it? The CT Lucia, we are implanting the CT Lucia, right? We are implanting the IQ. Okay, all right. Okay, fine. So if I am putting in a toric, yeah. No, you load. So if I'm putting in a toric, I would certainly put in some adrenaline here, because for toric alignment, I would need a larger pupil than this. For the normal monofocals or even trifocals or EDOFs without toricity, I don't need to dilate this pupil at all. This has maintained its physiology very well, as you can see, despite of the fact that the pupil started coming down. We have not traumatized it. So we're expecting the pupil sphincter to work very well post-operatively. That's exactly what we want. We don't want the patient to be photophobic post-operatively. We don't want the pupillary sphincter not to work. That's an interesting observation. You have the screw type. You don't have the push. You don't have the push type injector. No, but I would like to do it myself, sir. Where was I? Oh, so it's an interesting observation that we have done at our center. We see that the average Indian pupil, and I think the same dynamics will definitely work here at Bangladesh, pupil dilate 3 to 0.4 millimeters post-operatively. So if you have seen the pre-op pupil, hydro cannula. That's the aspiration cannula. Something I would like, hydro cannula. Aspiration isme laga dijiye. Okay. No, that's for the aspiration. Which is the irrigation? Oh, right, you're right. Yeah. Thank you. So the average pupil does dilate post-operatively. Now, it could be a little tricky to put in the IOL through a small pupil. Now, if that is a concern, then it is justified. So I go in with the hydro implantation of the IOL, the irrigation cannula in my left hand, and slowly pushing it. So the advancing haptic has to go into the bag. The pupil holds the optic, which dilates it a little bit. Dialer, please, Sinsky. And then through the other side port, this instrument goes in, catches the optic haptic junction, takes it to the bag and releases it. So you don't need to dilate the pupil for implant. Not that one, the bimanual aspiration. I have a little bit of cortex still left in the subincisional plane. I can see it. I'm sure you can see it as well. Yes. No, this is the aspiration handpiece. All right, so the aspiration handpiece. So this is the reason why I have the second side port. Even if I'm not using the bimanual IA routinely, I do have the instruments in my box, because these are the situations where it's actually needed. So though routinely I would use a coaxial, there would be situations wherein the fluidics of this machine are not working properly somehow. There are air bubbles or not giving me a proper anterior chamber. But anyways, we are through with it. So we don't aspiration a lot for visco aspiration, because except for Rexis, there was no other step where I used viscoelastic. So viscoelastic is not there to wash off. And this is one point that I will mention to. You have done a wonderful wound, wonderful surgery, but at the end of it, you liberate towards the fluid. And so in a properly done 2.2 millimeter incision, you actually don't need to hydrate the main wound at all. One side port hydration is an. As I loosen the speculum here, you will be well formed. Right now, since this is a self-retaining speculum, it puts some pressure on the globe, so it just squeezes out some fluid. So after removing the speculum, hydrocannula, please. This is just one final step, a small 0.1 milliliters of BSS being used to hydrate the stroma and form the AC, and then you're good to go. So no need to hydrate the main wound, no need to hydrate even the other side. Thank you so much for watching.
Thank you. Thank you, Dr. Misra. It's a wonderful surgery. So as you were discussing, it's impressive that you have minimized the energy, phaco energy or ultrasonic energy, and kept it up to the level of 5, which is really impressive. But I have seen that you have mostly used the mechanical part. Can you hear me, sir?
Just a moment.
Yeah.
So what I also would like to bring your attention to is, can we have the microscope view? No, sorry. All right.
Yeah.
What I would also like to draw your attention to is the aspiration time out here. This is a case summary.
Yeah.
The aspiration time is around 7 minutes, 11 seconds. And the total fluid that we have used for the whole procedure is 93 cc. So that is what is important. That's crux lies. It's less than 100 cc of fluid that we used for one surgery. Not only does it render the surgeries more economical, because with 100 cc, if you are completing one procedure, you've got 500 milliliters fluid in the bag. So that's almost 5 to 6 procedures per bag of BSS. So that's something that is very important. The total torsional amplitude on time was 1 minute, 20 seconds. So these are the factors you should look at when you are finished, when you're through with the things you should look at. I should minimize the fluid consumed. I should minimize the total. They are the factors that are going to assault the endothelium or injure the endothelium. So if you are keeping them down to a bare minimum, you will have shiningly clean, pristine cornea on the post-operative day. Thank you so much. Sorry, sir, I disturbed you. You can go back to your question. What?
Oh, yeah, that was I was asking that it's impressive that you have minimized the energy consumption as well as fluid consumption. And from my experience, I can tell if this set of surgery, I would have used energy up to the level of at least 13 or 15, sometimes near the 20. So this is impressive. But do you think that if we use the enough ultrasonic energy, little more like 10 plus 10 plus, we can save some time also? So if you look at the time, it was a little more time you have taken. That's quite impressive also.
So what you would have saved here, definitely not time, because if you use more energy in these cases, soft nuclei, you're only going to eat away the nucleus and you're not going to hold it. What I was doing was basically producing vacuum chop and mechanical chop. I was not even depending on the energy to getting consumed only when I went to the quad mode. Before that, it was hardly anything. So if you increase the energy here, you will be wasting more energy. These are very soft cataracts. These are soft cataracts. And they do warrant some time because there's a small pupil, because there's a soft cataract. So you do have to give some extra time to it. It's been my practice nowadays. It's been my practice for the last 2 or 3 years at least. We are not giving any corticosteroids post-operatively to the patient. That is basically because we are keeping the energy down to around 13. So if it's less than 13, the CDE count is less than 13, we are not to the patients. We give Nepafenac once a day. There's an OD formulation that comes from Novartis. It's preservative-free, no financial interest. So one drop of Nepafenac at 9 p.m. and then lubricants and antibiotics. That's all about the post-op regime. We are not giving any steroids. You can plan to do that only if you keep your energy counts low. Because when you know that the endothelium has suffered an insult in terms of fluid and energy consumed, you have to compensate for that with corticosteroids. Of our patients go out of the hospital without any corticosteroid drops or prescriptions in their hands.
Yeah, that's very impressive. So you said, if I just wanted to know again, you said that if it is the CDE is less than 30, then you don't give any steroid.
13.
13, 13. Okay. Okay, that's impressive. Thank you very much.
Medications for the IFI.
No, nothing. I don't give them anything. That doesn't help. Because it has tamsulosin works in the iris stroma plane, and it has already caused a damage there. It had the iris stroma tissue, which is normally very elastic. Tamsulosin fibroses them. So they stop being elastic. So that's the reason why it doesn't dilate. That's the reason why it behaves so rigid. If you stop tamsulosin, since the damage has already been done at the tissue plane, it's not going to help it. Rather, you should focus on keeping the wound tight and using low fluidics parameters to bail you out of that situation. Now, there's one interesting thing that has come, and I have also used it personally. If you have a very small pupil and you're expecting IFIS, where IFIS happens is actually the peripheral part of the iris. That's ballooned and that comes to the wound. So what helps is, if you stretch the pupil with a Milligan ring, if you place the Milligan ring initially, and then inject some pilocarpine intracamerally, the pilocarpine will taut the peripheral part of the iris, but it cannot constrict the pupil since you already have a pupil expander in place. That actually helps the IFIS very well. That used to when I was not playing around with my fluidics parameters. But that's a very important, very interesting observation that I have made.
Prakash, we cannot hear you. Prakash, we cannot hear you.
During hydrodissections, first you recommend single quadrant hydrodissections or multi-quadrant hydrodissections?
So it would depend.
Prevent prolapse of the iris.
Right. In this case, so the moment you see it can be single planar, it can be multiplanar, it would depend on the nucleus and when the hydrodissection is complete. But the important point to remember is the moment you see the fluid wave covering 2/3 of the posterior surface of or the anterior surface of the posterior capsule, meaning the fluid wave traverses from one end to the other, and once it's crossed midline and has come to 2/3 of its path, you should stop and bellot the nucleus. What you should not allow is a fluid egressing from the capsular bag and pushing the iris up. So that's something you should not allow. You should not also allow the flattening or shallowing of the anterior chamber while you're doing the hydro. So single or multi point is not the point. The point is the nucleus should be bellotted time and again, and the back should be decompressed so that there's no fluid wave that is causing the iris to go up.
Of the surgery, we have to create more pressure above the iris.
Right.
Okay, thank you everyone. I think we are running short of time. This is I think breakup time. If you have any questions, I will take it later on. Thank you so much.
Thank you, everybody.
That was a very informative learning session, watching the skills of the surgeons with live demonstration and brainstorming discussions. No doubt, all of them are amazing mentors despite being like excellent surgeons. Dr. Nahid Sultana will take over from here to conduct the next session. Before that, I'd like to announce that those of you who are interested, you can enjoy the refreshments served at the tea corner in the lounge now. Although the tea break has been shortened just by a few minutes, we hope to gather around this room around 11:20 a.m. once again to commence the next round of talks. And we will start the next session sharply in 20 minutes right in this room. Thank you so much.